We have Mike Rawaan, who is a great partner of the Center for the Business of Health. Let me get him up here, and I'll bring the real Mike over so he can stand in front of his ginormous picture. But actually, we want to thank Mike, first of all, as you can see up here, that he is the founder, president, and principal consultant at Covalence Health Consulting, but he's also an alum. So he, was it 2012? Oh, I was going to say 19, sorry. 2012 from our MBA program here at UNC as well. But again, too, he contributes a lot. He teaches courses, is a guest speaker. He helps the CBOH out a lot. But we're so glad to have him here because I think he's going to talk about something extraordinarily important. Again, a little bit about the consulting gigs, but more so about value-based care. So I think that this is really important from Mike's perspective. He has a long experience in this, and I could see him every time something very big was brought up. Whew, I saw his face. So he knows the business, and we are so happy to have him here. So we are going to let him, first of all, I want you to just introduce yourself, talk a little bit about your journey, but then I'd like you to dive into value-based care a little bit. But first, let's hear a little bit more about you.
Thank you, Suzanne. Thank you for inviting me, and thank you, everyone, for getting up so early this morning. Hope you're all caffeinated and energized, and I also a little upset because I have to follow Michelle. That's a tough act to follow. So, but here we go. So I'm Mike Rawaan. As mentioned, I am the founder, president, and principal consultant at Covalence Healthcare Consulting. We are a very, very small boutique consulting firm. We're focused exclusively in the healthcare industry. And we work across the board. And, you know, we've talked about some of the healthcare segments and the players when Dr. Stott was here. Who, by the way, was just teaching project management when I was here, so it's come a long way. Dean Stott, that's new for me. Really enjoyed this class, by the way. Okay, but I digress. So we work across the various segments of healthcare. Nearly $5 trillion. There's a lot of segments, but broadly we work with payers who are the health insurance companies. We work on the provider side, these are the doctors, the hospitals, so on and so forth. We work with services, so these are organizations that serve either one or the other side of that industry, and sometimes both. There's also a benefit management company like your pharmacy benefit management company, but there's other benefits that are outsourced as well by the payers and sometimes by providers. We also work with technology and digital health, that's huge. We also work with a lot of investors in the healthcare industry. So these are the private equity that Dr. Stott mentioned. Whether it's good or bad, that is a different question. We also work with a lot of venture capital, and these are the organizations that are funding new innovations that are trying to get into this industry. I started my career in the United States Marine Corps, and my job was to actually set up communication towers. I was a network operator and then eventually a systems administrator. And that sort of led me to get an associate's degree in communication technology. And so I was in technology when I started my career, and I wasn't in health. And so that's kind of me by training. I switched over to product development about 20 years ago, maybe a little over 20 years ago. And at the same time, I entered the healthcare industry. And I've been really fortunate because, as I mentioned, the various segments that my firm works on sort of is a manifestation of my career because I've worked on different sides of the industry with different organizations, supporting them largely in product development. And I do want to just clarify and just sort of set some I guess define what I mean by product and solution development. The way that we look at it, and I know that a lot of times when we talk about product, we talk about solutions, our mind, and when we talk about consulting, our mind kind of goes to technology. Technology is not a solution. Technology is a way to scale and automate a solution. A solution solves a business problem. So all my MBAs in here, you guys are going to be the problem solvers. You're not going to be out there coding. You're not going to be out there using ChatGPT. And I appreciate the question. I don't want to undermine it. It's a great question. But I just want to level set on that when I talk about designing solutions, we're talking about programs and different ways to do things that transform an organization's operations more than bringing in a technology and implementing that. So I'll pause there because I don't want to take up too much time.
That's a wonderful introduction. Thank you. Now, I'd love to know a little bit more about this value-based care. Can you tell me a little bit about it?
Yeah, and I think Dr. Stott brought up a couple of key concepts that I want to build on, both having to do with economics. One was incentives, and the other one was trade-offs, right? So who's had their economics class? Show of hands. Most of you. Okay, so you kind of understand the concept. I think that's foundational to economics, right? Economics is the study of behaviors when there's scarcity, right? And so one of those behaviors is trade-offs. We trade one thing for another, and that's how we sort of make our decisions. And incentives is a key concept within economics because if you want to change behaviors, you change the incentives. And that's really what value-based care is trying to do in the healthcare industry. It is trying to change behaviors by changing the incentives. Our classic model, which I believe is still anywhere from 70 to 75% of healthcare, is called fee-for-service. And I think, again, Dr. Stott explained that relatively well. I provide a service. There is a fee for that service that you pay me as a care provider. And how that's paid is typically a split between your health insurance and your out-of-pocket spending. But nonetheless, it's very transactional, and it's focused on your classic P times Q equals R formula. Now we're getting into finance. So that's basically price times quantity equals revenue, right? So if I'm a provider, what I'm trying to do, right, this is now second grade multiplication. I have a 7-year-old, so I'm teaching him this, is if you want to increase revenue, you just increase one of those two other variables, right? So your price, that's typically set because they're negotiated rates. And typically, we've talked about Medicare. Medicare kind of sets a baseline for what the prices of each of those services are. So you're kind of stuck with that. You can't charge more or you're going to price yourself out of the market. But what you can do is you can increase quantity. So you provide more services for the patients that you see and you increase your revenue. So where I'm trying to get to is you are incentivized for providing more services to your patients. Whether that's clinically appropriate or not is the question here. And again, I'm not going to play consulting. I'm going to try to play academic here today and not give you the answers, but ask those thought-provoking questions. What value-based is trying to do is basically flip that on its head. It's incentivizing the providers for doing the right thing and focusing on quality of care and the patient outcomes. And the way this effectively works with the economics is you look at the cost of care over a time period, whether that's 2-3 years, and understand what the baselines are. And then you challenge the provider and say, hey, I would like for you to provide care for a lower cost. And however much you lower that cost, I'm going to give you either a share of that or you can keep all of it. So an example is cost. I don't know what my PCP's cost for me is, but I'm just going to make up an easy number. Cost them $1,000 to basically take care of Mike and pay for Mike's healthcare for a calendar year. If my primary care physician goes into a value-based arrangement, he's likely going to get somewhere around, let's just say $900 instead of the $1,000, but he gets to keep all of that. Now, if he keeps me healthy and I don't go to the hospital, I don't need as many prescription drugs, and my healthcare utilization costs only, say, $800, that's $100 that he saved. And now he gets to keep that, or he splits that with the insurance company. And the insurance can be a private insurer like a Humana, United Healthcare, Aetna, so on and so forth, or it can be Medicare or Medicaid, who are, again, the largest payers in the industry. So I hope that's clear in terms of what value-based is and what it's trying to do.
So that leads us to the case study. So the Touchstone home, and yours was a little bit more beefy, so I wasted some trees. And so the groups will pull this on the way out. But if you'll just set the tone, and rather than coming up with specific recommendations, we have some discussion questions that will be at the end. But Mike, I'd like you to just kind of set let's give a 2-minute overview.
Yeah, absolutely, absolutely. So this is a real case or a real project that my company worked on several years ago. It was actually a couple of years ago. So this is a home health and hospice company that operates in the Mid-Atlantic. They came to us and they basically gave us all this background information, and they said, how can we optimize our growth? How can we effectively increase our profits? And one of the things they asked about was this concept of value-based care. And is there an opportunity for them to shift over into value-based care and be able to generate greater profits, but also they're also incentivized for patient outcomes, regardless of what type of value-based program they're in. So there's sort of a win-win situation for them where if they're in value-based care, you're incentivized to do the right thing, and by doing the right thing, you have all these additional bonuses that you can earn as well. So that's effectively the setup here. Is we have home health agency that has, you're not going to read through the stats in terms of what their payer mix split is, types of patients that they care for, and what effectively they're trying to do is, look, we feel like the market right now in terms of where we are is capped a little bit, right? There's not a lot of opportunity. We can only squeeze in so many visits for these patients and get paid more. So what else can we do? And again, I'll kind of go into the answer in terms of how we approach this. Again, trying to keep my academic hat on, but what effectively we're trying to do in terms of the discussion question is the approach to this, right? So as a consultant, you come into this organization, and keep in mind, people hire consultants for 2 reasons. I say people, I mean executives at that organization. Is number one is to augment your staff. You just don't have enough horses to basically carry something forward. Number 2 is you just have a gap in your knowledge and experience for trying to do something new. This is something new. They don't have the knowledge and experience within the organization to do that. So they bring in a consultant like myself and my team to help them with that. And so as you think about these questions, think about the process of how you would approach this. You're presented with this problem. What is sort of, project management 101? What is your first step? What is your second? What is your third, right? And I'll give you some of the answers here, if you will. There's going to be some research involved, right? There's going to be some discovery. You want to understand the problem better. But then you have to look for the solutions. And this is where things get really, really muddy, because there's never just one right answer, right? And so what do you do to make sure that you present the best recommendation to your client as a consultant, and all of this in the context of value-based care?
Thank you for that introduction. Again, too, as you saw with the last format, we're going to go out. I'm going to say 10 minutes. Each group can answer one of the questions. We'll come back and then start that discussion, and there may be additional questions, fabulous additional questions last time. So again, I brought some water down. There's water and more coffee in the other room, so as your groups go around, you can grab some of that. But please grab one of the papers, and guys, get on up again. See. Students.
Finished our talk later. I'm here. I don't know if it was over.
All right, everybody. We're going to call you back. Okay, again, we're going to have y'all contribute. So again, there were 3 questions. Oops, I'm going to back it up here. There were 3 discussion questions, and we'll just let y'all raise your hands and contribute any answers to those questions or questions about the questions that you might have. So begin.
Not everybody at once. I will pick on you. I think she mentioned I teach here sometimes.
Well, question 1. Oh,
I just had a question about the best way, or how you go about implementing these value-based models, these value-based care models into physician groups that aren't used to working with it, and they're more used to working with the fee-for-service and dealing with kind of, I guess, stubborn doctors and things like that.
That's a great question, and truly is one of the biggest challenges, because it's almost like saying, hey, You have to forget muscle memory over here and learn something new. And part of our job as consultants is really to almost project plan that and look at it from multiple facets, right? You have to change your operations. You have to change your clinical pathways sometimes. You have to change your behavior around technology adoption. You have to look at your patient mix a little bit differently and put your financial hat on. And also, you really have to kind of change your culture as an organization. So it truly is a transformation. And so how we approach that is really looking at it as a broader project of shifting the culture of an organization, right? How does Apple go from being a computer company to a technology and innovation company, right? It didn't happen overnight. It was a transformation that took a long time. So maybe not as big as Apple, but very, very similar approach.
Well, Claire mentioned the fact that we need to focus on prevention. So we need to invest in care management and care coordination so that they can check in on people and also just to make sure that they are doing okay. Baggy talked about like the technology aspect, so needed to invest in technology again for the prevention side of things so that you're saving money and all of that. So that's answering question 3, by the way.
Very cool, very cool. I love that, thank you. And Claire, thank you for that. Where's my Canadian? You brought up the question earlier, and one of the distinctions I always say, and I apologize for sounding cynical here, but we don't have a healthcare system, we have a sick care system. Canada has a healthcare system because they focus on prevention, right? And so that is a great input, is if you focus on prevention, then you are going to have less utilization of those sick care services, the hospitalizations, the surgeries that cost a lot of money. So that is absolutely one way to succeed in value-based care. So great input, thank you. Others?
I had kind of a question, maybe a comment. So for which VBC models, based on the payer mix and margins, with the Medicare, would it, because they're the older population?
And why does that matter?
Well, I think it would matter because there's more data on their conditions, what to expect from those type of patients, so it's not much guessing as far as how you all approach their care.
Okay. Anyone else? Anyone else want to add to that?
There's always guessing in management. There's a science, but then there's an art to it. I'm the only provider in the space, so I'm speaking to that. But yeah,
I love the science and art. Yes, absolutely, absolutely. Medical school only teaches you so much, right? The evidence and the guidelines only give you this sort of narrow the scope, right? But you still, as a physician, as a care provider, have to make those decisions. Let me build on that. It's absolutely correct. Medicare has greater opportunity, but it also has to do with the economics. Now, we can debate over whether there's more data for them or not. The physicians typically, they know their patient panel, especially if they've seen them before. But if you think about the Medicare population, there's greater opportunity there because there's greater utilization of healthcare services. Older populations tend to use more healthcare services because they're sicker, because they have chronic conditions like diabetes, because they have more hospitalizations. And so per capita, their cost of care is more. And that presents a larger opportunity for a home health agency to be able to be more preventative in how they behave and how they approach that population. What else?
Sorry, I guess another question. So when you start kind of looking at like population pyramids, like let's say 30 years from now, the U.S. like has an inverted population pyramid where there's just not many people, like the overall Medicaid usage just goes, or Medicare usage goes down. How do you, when you start taking those numbers into account?
We're talking 30 years from now?
Or like whenever, so like Korea, for example, there's like the replacement rate is just not there. So if you're like counting on having a large elderly population in 20 years, you're just not going to have it. So when you start...
I hope you're right. I absolutely hope you're right. But I would love to see our country get healthier and not have as many, but people are still aging, right? So they're going into Medicare and relying on that. Even if they're healthier, there's just going to be more people in Medicare. I do think it's going to shift, and I am being optimistic that people are going to get healthier, but they're also living longer. So they may not need those services at 70 years old. They just may need them later on in 80 years old. And I think Brad had a nice chart on life expectancy in our country, which I think the average is about 78, 79 now. A little lower for men. Sorry, guys. But that life expectancy is going to be higher as the population gets healthier. Did I answer your question?
Mostly, yeah.
Okay.
Sir, so I'm specifically looking at question 2. The model that I'd recommend to them is actually the ACO model.
Okay. And why is that?
The reason being is predominantly, right, their biggest profit margin, excluding self-pays, which they're their own unique thing, right? Those people have their own like purchasing power and ability to shop and buy as they wish. The predominant group that you're making money from is Medicare, right? So your elderly people. We're also noticing just on like the broad, like cultural side, a more shift towards, in the up and coming term, healthier lifestyles, which will impact for the next generation. So when Gen X and baby boomers become eligible for Medicare. So offering an ACO, right, if you take a healthy 65-year-old who never really smoked, didn't really drink anymore because it's not really much of a trend and exercises regularly, he's going to be a lot more incentivized, especially based off of the majority of their patients are from referrals. You're going to refer somebody where that cost is going to be eligible because he's not paying for the flip side. He's not paying for the outlier where this person has all these super rare conditions that cost an exorbitant amount of money because a mix of people misusing the government and how much they're willing to pay for things, and the R&D costs behind that. And if you looked at it from the flip side, where you did the bundled, you're looking at the opposite, where you're going to have a lot more of the healthier people not want to go and be referred to these because they're paying an across-the-board blanket for everybody and all their treatments that they need. So even if my lifestyle was like this, I don't need these, I'm being de-incentivized to go to you because I'm now paying for this group.
That's great, and looks, you put a lot of thought into it, so I love that, and I love the articulation. But it's a very important point because patient mix is going to be important, right? And you have to understand the behaviors of those patients, not just historically, but project them in the future. And so, great job there. And anything else? What else do we think about? So let me go to you first, and I'll come back to you. Okay.
Alright, our group actually took the opposite approach for question 2,
Okay.
and looking at bundle payments first with the consideration of ACOs for like long-term sustainability because of the patient mix, with wanting to focus on Medicare and then also the acknowledgement that Touchstone is health and hospice. So if you're offering hospice care with an older population, what is an improved outcome? I think that's like a discussion that would take longer to have. So that's why we were leaning towards bundled payments to start with the acknowledgement of our like, patient population and that aspect of hospice within Touchstone's business.
So are you looking at hospice as an outcome for home health patients, or are you saying that there is a different outcome from hospice?
Different outcome, like if Touchstone is offering hospice care, then how do you measure an improved outcome as?
There's definitely measures for that, right?
Okay.
So Medicare actually has specific metrics for a hospice in terms of what they define quality. Now, it's not outcomes-based because the outcome is, sorry to be bleak, death, right? But I love the perspective. I think, between you guys, you're thinking about this the right way in terms of how, as a consultant, we would approach value-based, right? Because it's not just whether you want to do value-based or not. If you're going to do value-based, the key question is what's the model, what population you want to do it in. So, great questions, and love how you guys are thinking about it. Sorry.
Real quick, I have a quick question before I give my answer. So I know earlier you were talking about how there are regulations in terms of what is quality care. With things like bundled contracts, is there any regulation on, what can be included in these types of contracts, or is that just completely provider's judgment?
That is a loaded question. So the answer is yes and no. There are a lot of guidelines and laws out there. I think someone asked about compliance and law and healthcare and how big that is. It's gigantic and it's table stakes. You have to follow rules, laws, guidelines. Compliance is it's never been really optional. And it's growing, right? Especially the emergence of AI. One of the biggest questions we have in healthcare about AI is does not have medical malpractice. So if AI is going to make clinical decision and it's wrong, we get sued, right? Compliance question. So when you go into value-based care, the rules do not change. You still have to follow the same guidelines when it comes to delivering care, reporting on care, HIPAA, which is protecting all of us, individuals and patients. All of those have to be followed. What is different is how you measure the quality of a provider in value-based care. And then when I say provider, not just the organization, but it's individual clinicians as well. So that changes slightly, but it's still looking at the same things. It's looking at patient outcomes. It's looking at patient satisfaction, but it's also looking at total cost of care and where you were able to drive savings.
So then I guess to answer the third question, one of the most pivotal things, especially for some like Touchstone, would be really key partnerships. And the reason for that is because when you're thinking about, okay, what defines successful value-based care, you're looking at lower readmissions, things like greater patient satisfaction, and bringing on completely new physicians or these new systems into play is extremely a really big financial uptaking to begin with. But if you're able to partner with the right physicians, create a really strong network of health professionals, you can leverage things like telemedicine and stuff like that, where you can really focus on providing the right care for the right patient at the right time, rather than having a whole bunch of individuals or a whole bunch of programs in place that are not going to be used at all times. And so that was kind of my answer to that. And then going back to the second question, it's an answer plus question. But with bundled payments, is there a way to maybe say we can provide 90 days of care, and then if there is a really extreme unexpected complication, if there's maybe a caveat that could be written into the contract saying, oh, you'd have to pay a separate predetermined amount? Because a lot of times you can have individuals that don't have any complications that are having to pay a rate that would maybe involve complications, and then vice versa. Yeah,
so on the second, there are mechanisms for that, right? So one of them is, how many have taken statistics? You know how to handle outliers? Okay. Right, you look at your alpha, and then your p-value has to be within the alpha, right? So you throw out the tails, basically. So that economic standpoint, that takes care of that. But you can also have something called carve-outs, okay? And a great example of that is end-stage renal disease, ESRD. Anytime you get into these bundled arrangements, that's typically carved out, because when a individual goes into ESRD, it's a whole different economic model, reimbursement model for those individuals. So that would be one example of an expected high-cost patient, because dialysis is not cheap. Neither is caring for the 20 other conditions they're going to have while they're on dialysis. So that would be an example of a carve-out. Sorry, was there another? Sorry, let me get back to you 1 second, because she had her hand up first.
We actually took the opposite approach for question 3 as well. In terms of before partnerships, we thought that data care coordination would be more critical, just because based on the data, 65% of patients are coming from hospital and physician referrals. So presumably there are already partnerships in place that we can rely on. So data care coordination would be crucial to just figuring out what the payment plan should be, what the best way to care for patients is, and how to use that data, maybe using AI models before you actually take care of patients through these
So being more informed about your population, and then where you sort of inject some of those interventions. Okay, sorry, go ahead. And by the way, guys, I don't have my glasses, so I can't read names. I apologize for not calling. I'm just pointing at you, okay? Go ahead.
And kind of like to add on to their point and as a rebuttal to you guys' point, I think data would also be a good investment. Just because I think that the data can actually, specifically when talking about data, investing in like impact reports for the company, I think that like the data and the impact reports actually would help with partnerships. If the company faces an obstacle of relying heavily on hospital and physician referrals, I think the company is going to have to put out a reason why they should refer their patients to the company. So if you did something like impact reports, like yearly or quarterly, something like that, it would enhance the visibility for partners and hospitals and physicians to be able to see the work that the company does. And it also provides an incentive for the company to provide that value-based care so they can put out good impact reports. So I think that data would actually go hand in hand with the partnerships.
Very good, very good. Love that, love that. Are we at time?
We are just about time. Let's do one more.
One more?
I saw a little
Okay. Do we see a hand? Somebody stretching?
I have a question practically about how bundled payment systems are implemented and what episodes of care get negotiated as being covered under a bundle and what remains fee for service.
Yeah, it's a great question. So the baseline is that there was a model called BPCI, Bundle Payment for Care Improvement, that was started, I want to say, back in 2012 by CMS, or actually CMMI. So one of the things that the ACA Obamacare Act did was to create CMMI, which is the Centers for Medicare and Medicaid Innovation. One of their initiatives was to create these innovative models to change the reimbursement in healthcare and move away from fee-for-service. And that really was one of the biggest drivers of value-based care. I don't want to call it sort of the mother because value-based care has been around. They sort of excelled it and propelled it into where it is right now. So that model actually has specific conditions and it had definitions around what an episode of care is and what services are included very, very specifically. That kind of became almost a framework for a lot of the models. But there is actually a lot of room for negotiations because now bundle payments have actually taken on many, many different formats, if you will. And I'll give you an example. A great example is actually cardiologist group. They want to take risk on heart failure and let's just say, what's another good one? Coronary artery disease, right? And what they would do effectively is they will partner with their payer and say, when individual goes to a hospital for these two conditions, hospitalization and 90 days of care, I'm responsible for that cost of care. Anything beyond that, it's not on me, right? But now that the implementation of the services and some of the tools we've talked about is very similar because even though it's not 365, it's only 90. Largest amount in terms of cost of care is going to be during those 90-day episodes, right? So now you have to still kind of implement the same tools and same services to care for that. But there's absolutely a room for negotiation. And when you do this as a physician group with a commercial payer, and when I say commercial, Medicare Advantage and Managed Medicaid is included in that, you get to kind of pick, to an extent, right? It's a negotiation. There's game theory involved in that as well. You get to pick kind of what you want to do and how much you want to move the needle as well. And the other thing you get to be a little bit more, I guess, prescriptive about, if you will, is you get to determine what the thresholds for some of those quality measures are as well. You still have to do them, right? You can't just do heart surgery and then roll the patient out and say, see ya. You still have to be responsible and basically provide the same level of care and high quality care. But you get to negotiate what some of those thresholds and some of those baselines are with those arrangements. Since she's not here, we can get away with one more.
With the different BBC models, these are not either or, right? Like a lot of times they complement each other, I would think, or are these like either or options?
Largely. They're either or, especially for the same population. You don't want overlap because the attribution is going to get really, really fuzzy. You don't know if a dollar's saved, you don't know how you saved it, right? And you don't know which, you can only attribute it to one program, right? You can't double dip. So 99% of the times, they're mutually exclusive.
Okay. And can everybody give Mike a hand? This was fantastic.
I'm going to do the picture too. Can you do the honors? Can you do the honors for me? Okay. No gang signs, please. This is going on LinkedIn, okay?
Healthcare. All right, so everybody's like.
I'm glad they didn't say Rawaan, because now you look like you're yawning.
There you go. Here you go.
All right, thank you so much. Thank you.
So next is lunch after we have our, I know I was going to say, but feel free to head on out. But again, connect with our guests on LinkedIn. Not only will you connect, but Mike has some awesome content. I am entertained constantly by you simplify some very complicated healthcare issues. So thank you so much. All righty.
I'll stick around. If others want to chat, have questions, I'm here all day. So happy to interact.
Terrific. So we'll have